Good evening, everyone, and welcome to the Bateman Horn Education meeting for March. We're so excited about the meeting tonight. Dr. Bateman is going to give us a summary of a really great clinicians meeting that we had here, hosted at the Bateman Horn Center, March 2nd and 3rd. It was really exciting. I was privileged to be able to be an observer here, and it was really touching to be in the room with this many clinicians who were so interested in ME/CFS and in furthering research on this disease. Dr. Bateman was the keynote speaker and the person who held it all together, so we'll turn the time over to her and let her tell you all about it. Dr. Bateman.
Thank you. Well, I'm delighted to be here to talk to you about our Clinicians Summit. This was probably the first of its kind, and we hope there will be many more like it. The summit goals were threefold: to lay a foundation for ongoing collaboration, to develop clinical knowledge for medical providers, and to identify clinical knowledge that might help researchers. And I'll give you a little more detail about our goals. So that goal number 1 was to propose mechanisms to support ongoing clinical collaboration in order to refine our clinical knowledge and increase the pool of experienced ME/CFS clinicians. We know that it's a very huge area of need to have more experienced and then trained ME/CFS clinicians. Goal number 2 was to summarize effective diagnostic and treatment methods and the science that supports them. So this is an effort to compile our clinical knowledge and back it up with science in a way that can convince maybe the skeptics and help provide information for clinicians in the future. We're hoping to put this information into a document that would be published and accessible to clinicians, along with a number of other avenues to guide clinicians. Summit goal number 3 was to rigorously distill the most important clinical knowledge and intuition from these experts that can guide and drive research. And I'll tell you a little bit about where that came from. So last August, there was a wonderful research symposium held at Stanford. And these were all the wonderful invited researchers who came to that Stanford symposium about the molecular basis of ME/CFS. Here's a bigger list showing all those wonderful scientists that were invited, and then you'll see that there was only one clinician at that scientific meeting. And because I am engaged in research with Ron Davis and as a clinical collaborator, he was kind enough to invite me to come to the meeting and not only be an observer, but to present a talk to the researchers. So the message of my talk at this research symposium was that patients with ME/CFS have a crisis: lack of access to modern health care. Because we don't have strong evidence, we don't have a strong evidence base, and we aren't even teaching physicians about ME/CFS based on the current scientific knowledge. So there's a very large gap. These are some statements taken from the Institute of Medicine, now the National Academy of Medicine, report recommending new clinical diagnostic criteria. The title of that report was Beyond ME/CFS, Redefining an Illness. And this is just a small part of that report documenting this dramatic need. So ME/CFS affects a million or more Americans, and if you multiply the overlap with fibromyalgia, you can probably increase that 5 times. The stunning thing is that by far the majority of people with ME/CFS have not been diagnosed. Those that are diagnosed may take years to get the appropriate diagnosis. We know that costs are very high to our economy, and yet less than a third of medical schools include ME/CFS specific information on the curriculum, and only 40% of medical textbooks include information on ME/CFS. And this extends to many, many ways that clinicians are trained and the way they're evaluated and credentialed. This was part of my talk. So I also said in the talk at the scientific symposium that these two critical needs, these are two critical but entwined needs. And the first is, we all know that we need research progress. We want biomarkers, we want to make a diagnosis, we want to know how to treat, and we know it's been underfunded and some of that is improving. But honestly, the second problem is access to trained and interested physicians. And one of they're interrelated. If we don't have trained, interested physicians, then the diagnosis isn't made, and then there aren't people to participate in research. So we've had in the past maybe 20 years a small number of very devoted expert clinicians who have well identified and evaluated patients who are offering those patients up to participate in research. But we shouldn't have such a small segment of the patient population as the only ones participating in research. In the long run, I mean, that can be a great start to help us decide where to go, but in the long run, if we want research to move forward, we need to have this illness diagnosed readily by clinicians and by specialists. So these are two very important needs. I also said at that conference that I relayed this quote also from the Institute of Medicine report in Chapter 8 that discusses how do we disseminate the Institute of Medicine report and all the information in it to medical providers. And this is interesting because this was an evidence-based review, and the conclusion was that the existing barriers are mostly attitude rather than knowledge. And there are doubts, misconceptions, the idea that it's only a mental illness, that it's not a distinct entity, that it's difficult to diagnose, and this is the worst one, that making a diagnosis won't help patients. That's kind of a pervasive attitude that's misinformed. The studies also show that MDs have low self-efficacy. They don't have confidence with this diagnosis. They lack expectation of a positive outcome and are not confident about making a diagnosis. So that is something that information, science, appropriate education can bridge that gap, and the first one. The other thing that the IOM report said is the name chronic fatigue syndrome and the short acronym CFS actually cause perceptions that the illness is less serious than reality. And this report recommended that we not use the term chronic fatigue syndrome, particularly in isolation. So at the end of the scientific meeting, and this is actually a picture from Ron at our meeting, but after I'd given the talk and talked about the knowledge barrier and the need for clinicians and how important it is for the science and the clinical aspect to come together, Ron stood up at the end of the conference and made a challenge. And he said, I challenge you to have a meeting similar to this for all the expert ME/CFS clinicians to guide us, help us know what it is we need to study and research. We don't know the clinical presentation of the illness, and of course many researchers do, but many researchers who come into the field don't have any experience with the clinical presentation and what it is they ought to be looking for in their scientific research. So because of this challenge, I decided that we would put this group together. I got the cooperation of Bateman Horn Center and the staff and all the support we have here at our nonprofit. We got a lot of help in putting this together, and I'll go through that more toward the end of the talk. But in accepting the challenge, we were able to hold our first annual ME/CFS Expert Clinicians Summit this past weekend on March 2nd and 3rd. It was pretty amazing. We had 13 experienced ME/CFS clinicians who traveled from all over the country and came together for 2 long days to strategize. And I can tell you this was not a typical kind of a scientific or clinical meeting. We brought these clinicians together in a round table format. The table wasn't quite round, but the whole idea was that everybody was on an even footing, and we designed the questions with pre-work and also in the design of our program to help these clinicians bring forth their experience, what they've learned about the disease in making a diagnosis, what are their tricks for management and treatment, and what do they think are going to be really important research targets. Now, the bottom line is most of what comes out of this Clinician Summit is going to be coming out later. We really just scratched the surface and sort of laid a groundwork for what we need to do in these three areas that are our primary goals. One is future collaboration plans. How can we get these clinicians, experienced clinicians, and include other experienced clinicians to create this important ongoing collaboration and kind of bring our ideas together and come up with the ideas that are most consistent and most helpful. Second is to develop clinical guidance for a new generation of clinicians. And third, to recommend research ideas for the new generation of scientists. I won't spend too long going through this, but I think it might be kind of important to understand who came to this meeting. These are not totally, we did not get all these bios from the individual attendees. These were bios that our staff put together, searching the internet and coming up with some things to inform our moderators about the background of these clinicians coming. So I'm sure that they could be much more amazing and glowing if we researched each one. But we'll kind of go in alphabetical order here. The first is Nancy Klimas, who is an double board certified in immunology and I think infectious diseases. I'm not sure, but she's been in the field for decades. You can see her on movies about ME/CFS. You can see her in Unrest. And she is now at the university, at Nova Southeastern University College of Osteopathic Medicine, and has created a wonderful clinical and research institute for neuroimmune medicine. She's been a wonderful spokesperson for the field and brings years of both clinical and research knowledge, especially from the standpoint of immunology. Dr. Tony Komaroff he came as a participant, but he is also our moderator, so we'll talk a little bit more about him. He is an internal medicine specialist at Harvard and has been treating and doing research on ME/CFS since the late 1980s when the very first case definition and the research on the outbreak started. He's been a wonderful spokesperson to help us create credibility for this illness, and he's been loyal and he's become one of the most wise spokespeople for the illness. We had Dr. Susan Levine, who is in private practice focusing on ME/CFS patients in New York. She is an infectious disease specialist and has been one of the clinicians involved in she was involved in the Chronic Fatigue Initiative, and she's also one of the clinicians involved in one of the recently announced NIH-funded collaborative research centers. She has been a clinical collaborator for years and also contributed to many published studies. We had Dr. Jose Montoya, who is a professor of medicine at Stanford and an infectious disease specialist who does both research and clinical management of patients with ME/CFS. Unfortunately, he became ill and was unable to attend in person, so we hope to loop him in as we move forward. We had Dr. Benjamin Nadelson, a neurologist who is the director of the Pain and Fatigue Study Center in New York. He has authored arguably the majority of papers of high quality papers that meet the highest standards of the evidence base throughout his career related to ME/CFS and also fibro. He's in some ways kept us firmly in the field of into the quality of evidence-based medicine by insisting on high quality of studies. He was a member of the Institute of Medicine committee that recommended new clinical diagnostic criteria for ME/CFS, and so was Nancy Klimas, by the way. Dan Peterson has been in the field He and Dr. Paul Cheney first became involved with ME/CFS during the outbreaks in Incline Village. And it was their investigation of the outbreaks that brought the Centers for Disease Control out and started the ball rolling to try to understand what might be causing this illness. And Dan has stayed firmly involved in the field, doing both clinical work and also working with the nonprofit Cimarron Research, which is devoted to redefining ME/CFS and moving the field forward. We invited David Kaufman, who graduated from New York Medical College. He's a partner in the Center for Complex Diseases in California that focuses on chronic fatigue syndrome, ME/CFS, mast cell activation, immunology, Lyme disease. So he's a very enthusiastic clinician with a background in HIV and some other areas of medicine who's entered the field to try to help understand the clinical presentation of these complicated patients. He hasn't been doing it quite as long, but I think he's less tired and very enthusiastic. Dr. Allison Bested was originally a hematology oncologist specialist in Canada who became interested in ME/CFS and fibromyalgia. And she has worked tirelessly and has the great respect of people not only in Canada but throughout the U.S. for her clinical experience, her writing, her treatment recommendations, and also she's been involved on almost every level. And we're so lucky because now she is in the U.S. and working at Nancy Klimas's practice at Nova Southeast and on the faculty. Most notably, she published a review of diagnosis and treatment of ME/CFS in 2015 that I think will serve as the basis for a lot of our work. Dr. John Chia is an infectious disease specialist with a medical degree from UCLA in California. He is passionate about his particular focus on enteroviruses and their possible role, and he has actively treated hundreds and hundreds of patients with potential infectious causes and trying to find treatments that will work for patients. Teresa Dell is a little bit more of a new entry to the field, but she brings some very special perspective. She has a PhD. She got her bachelor's in physical therapy and her master's of nursing and her doctorate of nursing. Then she came and did on-site training in ME/CFS in several clinics, including Dr. Montoya, Dr. Chia, and in my clinic, and has a practice in Flagstaff, Arizona. And she's just a delightful addition to the field. Dr. Richard Podell has just retired from his medical practice called Integrative Health Care for Complex Health Problems. He is a wonderful clinician, clinical professor at Rutgers Robert Wood Johnson Medical School. He's a Harvard graduate and brings many, many years of both clinical experience and a passion for educating patients and providing information. Dr. Charles Lapp, is double board certified in medicine and pediatrics. He also had an engineering degree before he went to medical school. He has been treating ME/CFS patients since the 1980s, shortly after the epidemic, first in collaboration with Dr. Paul Cheney, and then he set up his clinic at Hunter Hopkins Center. He has served on the CFS Advisory Committee, and he is part of the CDC multi-site study. I think I'm probably not naming this in every single person, but I just want you to know these are very, very, very experienced, involved clinicians who've devoted their practice and their career to making inroads toward both clinical and research progress in ME/CFS. I'll just say that my own path, because I'm one of the participants, to becoming an ME/CFS and FM clinical specialist started after medical school at Johns Hopkins. I practiced internal medicine for 10 years, but during that time saw many, many, many patients across this illness spectrum. So started a fatigue consultation clinic in 2000, also started doing research. And at the same time, I started a small nonprofit called Offer, run by volunteers as far back as 2001. In 2015, the board of Offer decided that we were going to change our name, rebrand the nonprofit, and see if we could really make more progress in this field, functioning as a nonprofit. So I became employed. I sort of gave them my patient population, closed my private practice, and became employed by the nonprofit. We also had observers, but they had very specified roles. This was a discussion of experienced clinicians. We invited Dr. Ron Davis, who started the ball rolling, and we had him come as one of our research liaisons. And we had Dr. Suzanne Vernon, who's the research director here at Bateman Horn Center, making sure we all stayed on track and listening and generating research ideas. We invited Miriam Tucker, who is a medical journalist and has published some very good articles, very high-quality articles related to ME/CFS. Her field is much more broad, but she's been very accurate and concise in her reporting. And we had Dr. Lily Chu and Dr. Maria Herman, who we sat in the back, and their job is going to be to help us as medical writers as we decide, as we move forward with these ideas, because we have all these busy clinicians, many of whom are now retired or trying to run their practice, and we want to be sure that we can move forward with our plans for publication. We had also the clinicians from Bateman Horn Center. We had Marianne Madsen that introduced me, our education director, and Stephanie Griffin, our communications director. We also asked invited Linda Tannenbaum of Open Medicine Foundation and Gary Solomon and his wife Rena to also be observers in our clinic, in our meetings. So that part was the kind of go through all the boring part, but it's good, right? So I'm going to show you some photos of our meeting because it's quite kind of fun. So you can see us sitting around the round table. We mostly know each other. I'll show you a few different photos, and then I'm going to go through and talk a little bit, maybe point out a few of these clinicians. So on the left, you can see there's me and Dr. Kaufman, Dr. Lapp, Dr. Bested, Dr. Levine, and then we'll keep going. There's Dr. Dowell and Dr. Klimas, Dr. Chia, Podell, Peterson, Nadelson, and Komaroff around the circle. Nice, small circle where we can all talk freely. We tried to plan our meetings so that we had 30-minute breaks and a long lunch hour so that everybody could share their ideas and establish or renew old ties. One of the most important things about our roundtable, our clinician summit, was we have two very amazing physician researchers to come and act as our moderators, Tony Komaroff and Dr. Will Deer. Dr. Komaroff, we talked about briefly. He has extensive experience as a clinician investigator, and as you can see, he has vast and amazing credentials. And his job was to, as the insider in ME/CFS, to help keep the group organized and focused and at a high level of quality in our discussion. Dr. Willard Deer is, I have to share this story, that he was one of my favorite attendings at the University of Utah when I did my internal medicine residency, because he was such a good clinical instructor, so clear, so precise, and such a good teacher. And taught me, especially, my favorite was he taught me how to do thyroid exams, which no one knows how to do very well. And I've been able to pass that on, I think, to the clinicians working here. And I can tell you I've diagnosed a lot of thyroid nodules and a lot of thyroid cancer in my career because of his good mentoring. After he was there, he went into the pharmaceutical industry, spent 28 years in the biopharmaceutical industry with extensive U.S. and international experience in clinical research. And he is now back at the University of Utah, the executive director in the Program for Personalized Health, and also the co-director of the Utah Center for Clinical and Translational Science. Clinical and translational science is to do good science and trials and engage clinicians in clinical research, to bring those connections together. So Dr. Deer has offered up the Utah Center for Clinical and Translational Science as a way for us to, in the future, educate physicians and engage in clinical trials. We brought him here as the critical thinking outsider, someone who could question our thoughts and our theories and add to the discussion. And he did a wonderful job. So here they are moderating up in the front. You can see we had a whiteboard and we were kind of doing Word documents and editing on the fly. I will mention that before this meeting, we sent out 9 homework assignments to all of the clinicians who were going to attend, asking them questions. They had to rate their treatments. We, asked how they evaluated patients, what kind of treatment modalities they use, and what they thought would be important research directions in a number of different ways of looking at this illness. The impaired function, the post-exertional malaise, disordered sleep, impairment in cognition, and orthostatic intolerance, along with their insights about the role of infection and the role of the immune system. So before we even started the meeting, we had compiled the information, we'd graded the drugs that the drugs we typically use, the kind of supplements they think might be helpful. Here you can see Mary Dimmock and Dr. Komarov. You can see, well, I won't go through all the names, but what I want you to see is this is a really great working environment where we were able to, everybody, there was no hierarchy here. Everybody was able to talk together and share their ideas. Here are a few other photos of that. And here is a photo showing our moderators were just as involved in the clinical discussion and as everyone else, bringing their ideas, encouraging the group discussion. So I'd like to take a few minutes and share with you some direction, maybe some of the things we talked about, but remember, this is not a final. This wasn't a meeting to come out and tell you the perfect treatments or the perfect thing in research. This was a chance to generate camaraderie, share ideas, learn from each other, and start the process along these areas. So, but the one thing I want to say is there was definitely consensus in this group around 2 things. One is that we want to use the term ME/CFS and help physicians become familiar with what ME means, myalgic encephalomyelitis, and avoid using the term chronic fatigue syndrome by itself. This is kind of important actually for just a practical reason, and that is that ICD-9 coding, that's diagnostic coding in doctors' offices, if you put chronic fatigue syndrome in this new coding, it defaults to chronic fatigue unspecified. Takes it to this big world of all kinds of chronic fatigue. If you put myalgic encephalomyelitis in, it goes to the correct code, which is post-viral fatigue syndromes, myalgic encephalomyelitis, and other illnesses in the neurologic section of coding. So that was a consensus. And the second was we actually talked about it and voted. There was unanimous rejection of the PACE trial recommendations using graded exercise therapy and cognitive behavioral therapy, GET and CBT, as evidence-based treatment recommendations for ME/CFS. So that is a strong voice. That doesn't mean that we don't have a place for education or a place for physical rehab, but these blanket recommendations are not helpful and may in some cases be harmful to our patients. So just to kind of whet your appetite about some of the things the group decided might be important, to remember the first goal was about collaboration and how we keep this going. So we decided as a group, I forgot to take the E out. Establish a listserv or other means of online communication among all of the participants, and then maybe inviting other physicians that are experts in the field to participate. We want to be able to share ideas and pursue projects without waiting too long, like a whole year, to talk together again. And this is to work on maybe publications, the idea of projects where we can help and assist clinicians in rural areas or clinicians who need training and along those lines. We made a commitment to do group teleconferences on a regular basis throughout the year in between to see if we can move toward individual assignments and working toward our goals. And we made a commitment. There was definitely excitement about, at a minimum, yearly in-person MECFS clinical meetings. This will require fundraising, donations, or something, because bringing people together is expensive. But it's one of the only ways we'll be able to make quick progress with this illness. So let's talk a little about the kind of clinical guidance this group would like to work on for providers. I think we hope to provide insight on billing and coding strategies, since it's kind of a big confusing mess. And then also the clinicians in the group felt it was really important to help patients with lifestyle changes, help teach them how to adapt to their illness, how to pace, how to live with orthostatic intolerance, how to maintain a little bit of physical conditioning in the face of this devastating illness. Other clinical guidance for providers that were discussed. This makes certain total sense, but how to help clinicians with clinical assessment and interventions, such as helpful tests and diagnostic studies. What are safe and helpful medications? What are safe and helpful supplements? So we'll be trying to develop that guidance for clinicians. High on the priority list of important top 10 interventions that listed by these clinicians was recognition of comorbid conditions, such as irritable bowel syndrome, allergies, and intolerances, mast cell dysregulation syndromes, nutritional deficiencies, hormone deficiencies. How do you assess sleep and provide help? How do you assess pain and provide the kind of support needed? And how do you identify and help patients manage orthostatic intolerance? So these were really high priority goals that everybody felt were important, and we'll be working on developing these ideas with more specifics and more consensus as we go down the road. So what about research directions? What did our group come up with? Well, I'm going to say we didn't come up with anything but a long list of potential ideas. We're in no way ready to recommend any particular research direction, but we'll be working on that. We hope to identify promising treatment trials. Everybody was enthusiastic about doing treatment trials. We need to take the things that we think are working and test them scientifically so we know we can advise them with confidence. And some of the things that came up, this is just a short list. I mean, this was such a long list that I'm just giving you a few ideas. Low-dose naltrexone, treatments for orthostatic intolerance, a drug like Immunovir that is an immune modulator, and the list goes on about promising treatment trials. We talked about research that would help us understand the underlying biology of ME/CFS. For example, the research we have on elevated lactate in brain ventricles and what studies are needed to help us understand the role of this devastating illness in the central nervous system. Natural killer cell dysfunction and abnormal cytokines, mitochondrial dysfunction, long list of things we'd love to see in how the research advance and clinical and have research lead toward important clinical endpoints and understanding the biology. And also not just understanding the biology, but developing diagnostic studies so that we can more objectively diagnose the illness. We for sure thought that additional research regarding enterovirus, for example, would be very helpful, just as an example. And how can we get neurocognitive testing that helps us identify the defect, and so it can be used in making a diagnosis. And then accessible, reliable testing for orthostatic intolerance. Again, these are just samples that I wanted to bring forward that are part of a much longer list. So that is basically the end of the summary. Much of what we need to do is going to happen in the future. And that's going to depend on our ability to carry this forward with those three important goals. And I want to really take a minute before maybe we take some questions to thank several people. One is Mary Dimmock, who is a tireless MECFS advocate. She was the event sponsor and co-organizer of this event. So think about the funding that might be necessary for travel, accommodation, meals, and she also put in probably hundreds of hours in pre-work planning, meeting, and helping with meeting notes, and was here on site helping in a number of ways. I want to thank Linda Tannenbaum for coming from Open Medicine Foundation, for helping with mostly being here as an enthusiastic collaborator, but also helping with some of the logistics about reimbursing those who came. I'd like to thank everybody at the Bateman Horn Center. Rob Entz is our executive director, Jill Peterson is our director of operations, and Carl Bredhauser is our financial expert here. But most of all, to point out Stephanie Griffin, who is our director of communications. She was a Clinicians Summit co-organizer with Mary, and spent, I don't know how many hours, hundreds, on pre-work planning, reservations, travel, catering, the facility, on-site facilitation, communications, and they were an amazing, amazing team. So thank you very much, and maybe I can take some questions if anyone's interested.
We do have an online question, and you probably need to repeat it because I don't think people can hear me. But they're asking if you are also focusing on pediatric.
So the question is, are we also focusing on pediatric? And I will say that the emphasis on this meeting was on the illness in general, but mostly focused on adults because the attendees were not pediatricians. I think we're all aware of the issues in pediatrics, but the pediatrics, there's many things that change in the treatment of a pediatric population. So we can take the principles that we know from these doctors who have worked across the lines, and that might be a great kind of clinician summit in the future. I will say that there was more of a virtual clinician summit in pediatrics, and a great group of pediatric experts in MECFS published very recently a treatment, an informative article about the presentation of disease and treatment approaches, and maybe we'll be able to provide that in the future. So that they're actually a little further ahead of us in having created this pretty up-to-date evidence-based document and guidance. I'm not prepared to give you the reference right now, so we can do that. Any other questions?
I have a question.
Mm-hmm.
So I was lucky enough to be there, and I remember Dr. Klimas making a comment about oxidative stress and making sure to evaluate that initially in an assessment. I don't know what that means, and I don't know if most of our audience knows what that means. So I thought maybe you could.
So the question is, Dr. Klimas talked quite a bit about oxidative stress, and wondering if, we don't have to explain it to our audience because I didn't bring it up in my talk.
Oh, okay.
But so I would say oxidative stress is helping the cell recover from activities that create cell death and Suzanne, how would you explain it? And the level of if there's mitochondrial dysfunction or other things going on in the cell, it's providing the nutrients that are needed, for the immune system to clean up the mess and properly bring the cell back into balance before you can do additional treatment. That's just kind of a lay person's view of it. But that is something that was a common theme, and we'll try to create some more insight and guidelines about that and as we come out with future documents. Suzanne?
One of the things that I thought was really exciting was the consensus about validating NK cell
Can you hear?
number and function.
Do you want to come up here and say something?
No, go ahead.
No, but it's not.
Repeat it. Just go ahead.
Okay, so
I think that was up on your thing, but I thought that was just so important because the field in general has really been clamoring for that, and that has so many implications. I think.
Right. So Suzanne's comment are about the consensus around the importance of natural killer cell function as a marker for this disease, and also as something that might lead us toward understanding the pathophysiology of this disease. The Institute of Medicine report listed natural killer cell function as the most consistent finding in the evidence-based review. So we have a lot of work to do to bring that to the forefront, do studies that maybe confirm this additionally, and also make it possible for clinicians to obtain this test, which isn't really always easy to find, or at least not easily done in the correct manner. One of the problems with natural killer cell function testing is the blood needs to be analyzed quickly after it's drawn. It can't be heated or frozen, and needs to be analyzed within the first 24 hours. So that creates some barriers for shipping blood or sending it to a regional lab. So this will be a part of our recommendations and emphasis as well.
Do you have a plan for enticing new medical talent into the research and educational field of MECFS?
So the question is, do you have a plan for enticing new clinicians and researchers into the MECFS field? Well, I can say that the way I look at it is, if we provide them good information, they'll be interested. So we need to get over the gap of, this illness being kind of pushed out into some kind of a periphery and stereotyped. And I think the best way to accomplish that is with sort of what we said in the beginning. Number one is we need to do more science. We need to add to the evidence base. It needs to be high quality. But we also need to inform clinicians of the current science. And I think that's been a very big gap. I think we have a wonderful wonderful amount of science that's intriguing and helps support almost everything we know about this illness. And I sometimes, when I give a talk to specialists or clinicians, I just go down the Institute of Medicine diagnostic criteria and list some studies that supports that being the most evidence-based diagnostic criteria. With the diagnostic criteria were designed by looking into all the studies of people with this illness and looking at the common core symptoms that that present with this illness. And those Institute of Medicine criteria, they're not all of the illness manifestations, but the illness manifestations that seem to be the common denominator and core to every patient. And basically that's an illness that kind of manifests as fatigue but results in significant functional impairment, difficulty doing normal activities. The second is post-exertional malaise. And the way I look at that is, that's what happens if you try to exceed your functional impairment, if you try to do more, try to push yourself beyond that low functional capacity. We have science to support the impairment in function. We have science to support the illness consequence of extra activity of post-exertional malaise. And the next criteria is unrefreshing sleep. There's a large science around sleep. We don't have all the answers, but there's a big evidence base, big chapter in the Institute of Medicine report about all the studies that have been done to study sleep. Cognitive impairment, the IOM report showed very clearly, reviewing all the cognitive studies, that patients with MECFS have impaired, cognitive slowing, impaired reaction time, trouble with short-term memory and concentration. Or the flip side is, and there's a big population of people who make the criteria of that, or orthostatic intolerance syndromes, which kind of create a different kind of cognitive dysfunction and impairment. So the criteria let you swing between the presence of orthostatic intolerance or significant cognitive impairment. Then the Institute of Medicine diagnostic criteria, well, first of all, those core symptoms must be present at least 50% of the time and be moderate to severe. That's the most important thing to apply to the diagnostic criteria, other than it has to have been present for more than 3 to 6 months, 3 in the pediatric and 6 months in the adults, to have a confirmed final diagnosis. But the IOM criteria recognize that there are pain syndromes, there are immune manifestations, there are maybe signs and evidence of possible infection in terms of starting the illness, in terms of aggravating the illness, and many other aspects, but none of them are totally proven. But we have a great evidence base starting to support those criteria. So I think getting that communication to the right people will excite clinical providers and get them involved.
You should tell your story about the one doc that is diagnosing now because of the IOM report.
Yes, so I was in a meeting with a group of people who are planning a continuing medical education course, and one of the invited professors was a very experienced, renowned rheumatologist. And we were just chatting unofficially, and she said that the IOM criteria completely changed her practice, because once she understood the difference of this illness and other illnesses that come into her clinic, including fibromyalgia, that doesn't meet criteria. She said all of a sudden her eyes were opened and she realized all the times that she'd missed this and became more adept at making the diagnosis. Unfortunately, then she said, and then I tried to refer him to an MECFS specialist, and I said, guess what? There aren't enough of those, so you're going to have to suck it up and learn how to do this illness. I didn't use quite those terms. But no, it was a really great experience. I've also had wonderful experiences with specialists here at the University of Utah. Have great chance to present and discuss this illness with the neuroscience department, with the chronic pain specialists, with the specialists in the sleep lab. Given the right information, they all had open minds and enthusiastic desire to learn more about the illness and learn how it applies in their specialty. So I'm very optimistic that if we can get organized and pull all of this together and create the documentation we need, we're going to be able to move the field forward.
Was fibro discussed in this context at the meeting and how it intersects with MECFS?
So the question is, was fibro discussed in this meeting? And you can't talk about MECFS without talking about widespread chronic pain and hyperalgesia. So the meeting was more the focus of MECFS, and we know that a large portion of MECFS meet fibro criteria, so they really are a fibro patient. And I would say that the meeting was not focused on fibromyalgia patients that don't meet the MECFS criteria, and that's okay, because those patients they're a decade ahead of us in terms of the development of medications, the science, it's not perfect for people with fibro, but it's a lot better for them than for people with MECFS. We also know that if you meet criteria for MECFS and fibro, you're sicker than people who just meet the MECFS criteria. So the combination of other syndromes can really create a complex and debilitating illness presentation. That includes the overlay of multiple chemical sensitivities, et cetera. There's actually a chart in the Institute of Medicine report that shows the severity of illness based on the SF36 determination, which is a questionnaire that the more illnesses or illness descriptions you combine, the more debilitated and sick patients are.
Were you surprised by anything that came out of the meeting?
So the question is, was I surprised about anything that came out of the meeting? Not really. What's really cool is we invited 12 people. They all accepted, and they all came except Dr. Montoya, who got sick. Everybody loved it. I wasn't surprised. I think some people might be surprised, but I've worked with this group of people for a long time, and we care about each other. We respect each other. We're all isolated in general, in little pockets, under-resourced, and trying to do our thing in our peripheral, isolated way. But what's wonderful is you can take these people who come from different fields, have different practices, and you can come together, and it's amazing what everybody can observe in common. Those are the clinical pearls. That means it's the core features of this illness. So it actually makes it stronger, I think, to bring everybody together. What I maybe was a little surprised at was how hard it was and how complicated it was, way beyond sort of my naive plan to bring people together and get the information and organize it. So, but that's good. That's probably reflective of the real problem. That there's many dimensions, many hypotheses, subgroups of patients. It may be that our treatments really need to be pointed toward a certain presentation of illness, not a global recommendation for all people who meet the MECFS criteria. And there's nobody better than experienced clinicians to help identify those subgroups, which can then be looked at by researchers and maybe delineated a little bit more with data. Yes?
What would you say is the most important or the most meaningful thing that came out of this conference?
I think, so the question is, what was the most important and meaningful thing that came out of this conference? I think it was simply bringing these researchers together and letting them form a collaboration and start to communicate. Because that's been lacking, and because there were no vehicles and funding and ways to do it. We have had a wonderful scientific conference every other year for many years, sponsored by the IACFSME, which is a scientific organization that exists mostly to put on every other year conferences. But the focus of those conferences has been the research. And people come and present their papers and posters and talk about their research. We've started to do a little bit of stuff for the clinicians, but not this way. Not bringing the experienced clinicians together and putting them all together and saying, what are the common threads that are super important? So we can take these common threads in patients with illness and push it forward, test it, and create a uniform voice that can speak authoritatively to clinicians and researchers. I think this is particularly important, for example, in the unified voice about the PACE criteria and whether or not, because right now, you can argue all kinds of things about the research, but right now, because that one trial was big and evidence-based, and what came out of it was the advice for graded exercise therapy and cognitive behavioral therapy, on many resources, that's the only treatment listed as a treatment for ME/CFS. So it's so imbalanced and so out of proportion and so uninsightful. My personal opinion is that they included way too many other illnesses in their study, including patients with fibromyalgia and other kinds of chronic fatigue. And honestly, in other patient groups, those are good recommendations. But for this particular group, as you can probably tell based on the diagnostic criteria, graded exercise or trying to get yourself in shape and increasing the exercise is just not helpful. And it can cause relapse and can cause patients to become more ill. And sometimes that kind of activity can create new symptoms that are permanent. And I've seen that. I've seen people develop widespread pain after cardiopulmonary exercise testing that never goes away. So patients come, they sacrifice themselves and their well-being to participate in research. But that's different because that is an important and lasting piece of research that changes the field. But having people go out and do things when their illness will worsen is just not good. So that was a really important thing that came out of it. And maybe that surprised me a little bit. It didn't, but it was really fun after kind of coming from all directions and agreeing and disagreeing and doing everything. Toward the end we said, so by a show of hands, how do you feel about the PACE criteria? Boom, every hand went up around the circle that we reject that as an evidence-based treatment, and particularly that it should ever be listed as the only treatment. So that was fun. I forgot the question now. Any other questions? I love talking. Kind of went on a tangent. I would say that it was an inspiring weekend for me. It was fun to see my friends and see them excited and enthusiastic about not being stuck in a rut and not having no voice, being voiceless. That was kind of double negative, not having no voice. But what they were able to is they found their voice. It was a safe place for us to all talk, collaborate, confirm our observations. And I think that's going to empower all of the clinicians, and hopefully we can speak with an authoritative voice that will help us overcome the barriers. So thank you. And if anybody wants to drum up fundraising and or write grants or do things to help us fund these future collaborations, that would be great. And we're also we're just devoted to doing it one way or another, but it would be nice to do it in person as much as we can, because things are just a little different when you're talking on the telephone or in a teleconference. Thank you.